I'm Mark Levis from the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins here in Baltimore, Maryland. Uh, and the question before us is, what is the current clinical landscape of FLT3 inhibitors in the treatment of AML, and what insights have been gained from trials so far? I think the primary insight is patients with FLT3 mutant AML should be, whenever possible, treated with FLT3 inhibitors. The problem, of course, is we haven't quite sorted out which FLT3 inhibitors to use and under what circumstances. There are literally 4 FLT3 inhibitors running around the world right now: sorafenib, midostaurin, gilteritinib, quizartinib. They all have different properties and different regulatory statuses and are not available worldwide uniformly. Nonetheless, it is essential that they be a part of management of FLT3 mutant AML. The things we haven't learned are which one is better. Oftentimes that's determined only by what's available, but right now we haven't sorted out whether quizartinib is better than midostaurin, is better than gilteritinib in any particular circumstance. And a bigger challenge, I would say, is how to use these drugs in the setting of a patient who is not fit for intensive therapy. And here is, I think, the big challenge facing the community, and we have not found a good way to address this in clinical trials. Older patients with AML are treated now with less intensive therapies, typically azacitidine and venetoclax. How do you incorporate a FLT3 inhibitor into that? But it's very clear you should in some way. And so the clinical trials have presented to us concept that FLT3 inhibitors seem to always lead to improvement in survival, but how to incorporate them into standard treatment regimens that continue to evolve. Aza-ven, intensive induction, which we're modifying, also making it more intensive or adding other drugs, including venetoclax, how to incorporate it into allogeneic transplant. And one particular tool that I think clinical trials are revealing to us is the use of measurable residual disease, MRD. However you use these drugs, you can frequently use MRD to track the disease in remission and guide the use of FLT3 inhibitors. So the big picture is, from clinical trials, FLT3 inhibitors are an essential component of therapy for a patient with FLT3 mutant AML, but we haven't quite learned which drug is best under which circumstances and with which regimen. And we've learned that MRD, particularly for FLT3 ITD mutations, can really help guide clinicians in the management of these patients. So a lot of progress has been made, but still a lot of work to be done.